Okay, good afternoon, everyone. Let me introduce myself. I'm Dr. Brigadier Murthy. I'm the Prof of Anesthesia, and I've been a member of ISCCM for many decades. Today's topic is a very important topic for everyone, for all those who have joined me. My emphasis on today's talk will be especially to the nursing people, besides if any other graduates have come onto the link. Now, shock is one which we day in and day out see in our clinical practice, and it is a very important finding which we recognize, diagnose, and if we don't intervene in time, it can give rise to deleterious effects, at times leading to irreversible effects. It's a whole spectrum which runs from the beginning till the ending, till it lands up into complications. I would like to divide my talk for the convenience and the brevity and for the sake of everyone who are with me on this link into definition, classification, pathophysiology, and the stages of shock which we see and recognize, and how to manage them. A shock can be usually defined as a state of circulatory failure where there is some problem resulting into delivery of sufficient oxygen failure to balance the demands of the tissues. And this results into a condition called as tissue hypoxia, which is very, very serious. And the effects of shock are reversible if it is diagnosed and can be treated in the early stages. And any delay in the diagnosis due to whatever reason or a timely initiation of treatment can all lead to irreversible changes, including multi-organ failure and death. So when we land up into that entity of multi-organ failure and death, then our treatment becomes really challenging and it may land up into severe morbidity, if not a mortality. Now, what are the various types which we usually see as per the pathophysiology? We'll go into each over the slides in the coming few minutes. But basically, shock is classified and divided into distributive, which occupies the major chunk. Cardiogenic, more or less same, but it occupies the second place in the incidence. Hypovolemic, which is usually seen due to various conditions, and the commonest is you lose blood because of the common denominator nowadays is road traffic accidents and trauma. And the last but not the least is the obstructive. So we have these four types broadly divided, and shock can be any of these types. This is a small caricature to show that cardiogenic shock is basically as the result of a severe myocardial infarction, pulmonary embolism, cardiac tamponade. Arrhythmias are also possible to cause cardiogenic shock, but they're not that common as compared to the other three. Hypovolemia, usually seen in hemorrhage, severe dehydration, severe burns, and we lose intravascular volume significantly, giving rise to the uncascading of the various steps, which leads to tissue hypoxia. The greatest and the more evident and the frequently seen shock type is the following sepsis, which is very prevalent nowadays due to various reasons. And it lands up into vasodilation because of the endotoxins, endothelial damage, capillary leakage, and it lands up into fall in the blood volume and the deleterious effects of it, giving rise to end organ damage, multi-organ dysfunction, and tissue hypoxia, and probably a cell death. The last one, which we usually see most of the times, is anaphylactic. It's Though it's well described, it's not commonly seen. And that is because of the eosinophil and the mast cell degranulation, because of a type 1 hypersensitivity, which is an immunoglobulin related and can give rise to generalized vasodilation. There's no obvious loss of everything is, but it is shifted from the intravascular to the extravascular, giving rise to the shock condition. Pathophysiology, whether it is which type of shock, the pathophysiology is basically same. Inadequate perfusion, the cellular hypoxia, the loss of energy, there's a lactate accumulation, and if you really study the biochemistry, there will be fall in the pH and makes it into an acidotic milieu. All this because the required oxygen levels are not there and it lands up into the anaerobic metabolism. This can result into a state called as metabolic acidosis, which gets more aggravated because of vasoconstriction, failure of these precapillary sphincters, pooling of blood, and not being able for circulation. And all these can give rise to sodium pump, which is the most important part of the function of the body. And it can destabilize the cell membrane and release of certain enzymes, toxic substances, damage the capillary endothelium and further destruction and cause cell death. In the same time, we have certain elements which are okay if they are in the normal range, and they are otherwise they can play havoc with the homeostasis in the body, and that's because they cause an efflux of the potassium and an influx of sodium and water, and giving rise to the deleterious condition of the shock. All this can result into peripheral cyanosis, fall in urine output. On the clinical monitor, one finds tachycardia, hypotension. So most of the nursing professionals who are dealing with patients will usually see tachycardia, hypotension, tachypnea, and also a significant history of a low urine output. And when you try and measure the SATs, it will be low. There'll be an altered mental status. The individual will be restless, not listening to your commands, and the extremities will be very cool because of the peripheral cyanosis and vasoconstriction. What are the things which are very important in evaluation when it becomes that you should attend the shock patient at that time in an undifferentiated shock? Is the evaluation principles are more or less similar for all the types of shock: a good and essential and a brief history, a thorough physical examination, a 12-lead ECG. All the nurses are capable of doing this. Send bloods for the complete blood picture, liver function tests and the renal function tests, electrolytes and serum lactate levels. The other things which we also have to do, which are of importance for us to corner onto which diagnosis we want to know why this sort of a clinical picture is there, are the cardiac biomarkers, because it can mimic certain conditions of the heart which have to be dealt with rather than trying to pump fluids into the patient. Estimate the D dimers, coag profile, try and know the blood grouping and typing, get the the arterial blood gas. The chest X-ray is mandatory in most of these cases, and in selected cases, we usually also ask for, depending upon the clinical profile, we usually ask for CT of the chest if necessary, and do an ultrasound of the abdomen and a cardiac echo to know the cardiac status. So these are the basic and essential investigations one has to do in trying to go about of the evaluation of an undifferentiated shock. Now, the whole spectrum of shock runs through various stages, and usually it is the pre-shock or the compensated. In the pre-shock or the compensated, we usually find tachycardia, peripheral sinus, peripheral constriction, vasoconstriction, changes in the systemic blood pressure, which is usually a hypotension. These are all indicative that the shock cascade has got unleashed, and there is a series of cascades which are opening up. At this point of time, if we recognize and diagnose probably a shock due to so and so reason, then our outcomes are usually good. It can land up from that stage into an existence shock, and where the mechanisms of compensation, where they become insufficient, and they start showing up classical signs and symptoms of shock due to early organ dysfunction, and it can give rise to later into organ dysfunction in the form of multi-organ failure and death. The overview of the various shocks which the topic is can be identified and learned, whether it is hypovolemic, cardiogenic, extracardiac, obstructive, or a distributive. Whatever is the reason in which the shock is setting in, all end up in the final common cascade, which is fall in the cardiac output, increase in the systemic vascular resistance as a method of trying to save the effects of the shock, a decrease in the mean arterial pressure, shock, and multi-organ dysfunction. So one has to pay attention to the individual varieties. For example, hypovolemia, in most of the cases of hypovolemia, it is because of hemorrhage. Cardiogenic is basically because there is some damage to the myocardium. Most common thing which lands up into cardiogenic shock is myocardial infarction. Extracardiac obstruction, and it can be because of a fall in the diastolic filling or an increase in the ventricular afterload. So the commonest thing is tension pneumothorax or the pericardial tamponade. And if you recognize this well in time, you can immediately give relief to the patient. And ventricular afterload, massive pulmonary embolism, this can be treated once it is recognized, and you can set things right once remedial measures are taken. The distributive shock, the common example is sepsis, and you have to treat it accordingly. The most common of all the shock types are the distributive shock. It is because of the vasodilation which occurs and associated with the low systemic vascular resistance. It's one of the unique types of shock, and there is a compensatory increase in the cardiac output in all these causes initially, which later fails at a later stage. If we measure the central venous pressure, it is low, and usually nowadays we don't measure the pulmonary capillary wedge pressures because we don't require to do that highly invasive investigation, but we can get ample evidence only from CVP. What are the main causes of distributive? As I told you, the majority, in about 60 to 70% of the cases, it is septic shock. The other things which contribute to the distributive shock are the other, like non-septic, anaphylaxis, neurogenic shock, and others, especially toxic shock syndrome, liver cell failure, transfusion reactions, so on and so forth. So one has to know that distributive shock, the main chunk of the distributive shock entity is usually nowadays because of sepsis. Now, sepsis is, you all are aware of sepsis because I think in every 10 admissions, at least 3 or 4 will be sepsis, and it associated complications, and the patients usually present in some level of the spectrum of the severity of the sepsis. It's basically because of the dysregulated host response to infection, and it can result in life-threatening organ dysfunction. When it is accompanied by persistent hypertension, see, the word important over here is persistent hypotension, then it's the time that we should press the button of vasopressor support, and then one can term it and put it in the category of septic shock. What the septic shock, understanding shock, has been revolutionized, revised, evaluated over a period of years. And every 2 to 3 years, we keep getting the international consensus on the understanding and the definition of the shock with some minor changes. As per the latest guidelines of 2021, with some changes little later, we usually used to have a 6-hour and a 3-hour bundles. These bundles are the one for all the nursing people. Bundles are the procedures which are grouped into one category, which one has to do and get ready with these bundles as soon as possible if you identify shock. Now it has come down to, we are becoming more defensive as far as septic shock is concerned. Previously it used to be 6 hours, then it trickled down to 3 hours, now it is 1 hour. Probably in some time we may come down below 1 hour. Now the 1 hour bundle of sepsis basically encompasses measuring lactate, taking blood for culture, starting antibiotic therapy, fluid resuscitation, and initiation of vasopressor. Now over here you see the essential details have been mentioned. Measure lactate and anything. If you see the blood gas picture, that is the arterial blood gas analysis, which is a very vital piece of investigation, and you'll get the lactates. But you have to do a blood gas which has a lactate estimation. Anything more than 2, that means there is something going wrong. Blood culture, you send at least 2 sets of samples, and this has to be taken, collected, and sent from 2 different sites of the patient and send it for culture. And start empirical therapy with the antibiotics as soon as possible. And what antibiotic to start is depending upon the institutional protocol. We usually have each institution having the bug of the month by our hospital infection committee dictates, and based on that we usually start with our empirical broad spectrum antibiotic and fluid resuscitation at the level of 30 ml per kilo crystalloids to tackle hypertension, or whenever the lactate levels are more than 4, and start administering the vasopressor for persistent hypertension. To our targets in sepsis is to maintain a mean arterial pressure of more than 65 always. Otherwise, you will be hampering and jeopardizing the target organs, that is the heart, kidney, and the brain, and it can give rise to irreversible damage. If it is an anaphylactic shock, it's predominantly because of IgE-mediated allergic reaction. It can come because of food, medication, or an insect bite. And there'll be a profound distributed, there'll be profound vasodilation because these are all mediated through histamine release. And in this, there is both not only venous, which is usually seen in the other types of shock, but it is also in the arterial vasodilation. Now we have the algorithm for diagnosing the anaphylaxis. You try and diagnose with a proper history, you'll be able to usually put your hand on the anaphylaxis angle and then look at the basics of A, B, C, D, E, which includes the airway breathing, circulation, disability, and exposure. Diagnose empirically what's wrong, and if it is anaphylaxis, and call for the help for your resuscitative team and give the drug of choice. The gold standard of management is to correct the fluid balance and give intramuscular adrenaline. There are various regimes which are to be followed as far as intramuscular adrenaline is concerned. And if it is a life-threatening problem which is accompanying the status, you have to tackle that accordingly and see that the airway is kept patent, either with inherent natural or established airway. And give IV fluid therapy. In adults, it is about bolus of 500 to about 1 liter. In children, it is about 10 ml per kilo. So these things have to be re-evaluated after every 5 minutes. In pediatric age group, when you don't get the vascular excess, one can try and go for intraosseous. And the common site for intraosseous will be the anterolateral aspect of the thigh with an intraosseous needle, which is very safe. And you can push in fluids so that the individual can be saved and time is not lost in trying to get a venous access. The other type of shock which is usually seen is the neurogenic, and usually seen in spinal cord or brain injury, and it gives rise to the changes in the autonomic pathways and which regulate the tone of the vasculature, and it also reduces the systemic vascular resistance and develops a fall in the venous return, and it culminates into fall in the cardiac activity or the cardiac output and lands up into a neurogenic shock. And basically, this type of shock is usually seen because of the imbalance between the sympathetic and the parasympathetic. The most important crucial word over here is the vasodilation, and one has to attend to it to see that this is tackled well in time. Most common clinical entities of neurogenic shock are the spinal cord injuries, anything more than T5 above. It can, at times, a very high spinal anesthesia can cause, but it is not that common. And certain drugs, especially pain relievers and hypoglycemia, can cause some sort of a neurogenic shock. But these are not the regular things, but spinal cord injury is very commonly seen with a neurogenic shock. Now, as the class is more towards improving the nursing standards and to see that the continuing medical nursing education is kept at a very high standard. Nursing management for individual varieties of shock, I would like to press on certain aspects. Basically, immobilize of the patient is very important, especially if it is a spinal cord injury. You can give a collar if it is a cervical spine, or you can give some sort of a stabilization if it is a thoracic spine. Administer IV fluids to take care of the vasodilation mediated effects of hypertension. The drug of choice in these places is dopamine, and in addition to the fluids. And if it is a high cervical cord injury, it is usually the atropine which is the drug of choice because it causes a lot of bradycardia. Now, the good thing about the nursing management is, though it is not yet confirmed and there are a lot of debatable issues on the use of high doses of steroids, but within the window period is about 4 to 6 hours, and within the window period, if you receive the case with a spinal shock with a clinical and radiological evidence of a spinal cord injury, it is worthwhile trying steroids in some way or the other so that you can salvage the patient before it goes into an irreversible state. If it is a hypovolemic, if it is non-hemorrhagic, it's basically because of various conditions like vomiting, diarrhea due to some reason, or it can be drug-related overdiuresis, diabetic ketoacidosis, or some infection in the tummy in the form of peritonitis, burns, pancreatitis. These are usually non-hemorrhagic, but in hemorrhagic, it's usually the gastrointestinal bleed. I would like to categorize the hemorrhagic into basically hypovolemia because of trauma. That is the first and foremost, which we see day in and day out. The other things which have to be kept in mind based on the history is either a GI bleed, retroperitoneal bleed. Basically, retroperitoneal bleeds are also because of trauma. Until and unless other not very common examples are ruptured aortic aneurysm and all. Ruptured ectopic pregnancy, it causes severe degree of hypovolemic shock, and one has to have this sense of recognizing the same and acting as soon as possible. Postpartum bleeding, hemothorax, these are the classical examples of the hypovolemic shock. Usually characterized by fall in the intravascular volume, and they have to be maintained accordingly, and because of then you can initiate and see that the body responds to the compensatory mechanisms. If not, otherwise the later stages, the shock due to progressive volume depletion usually takes place and manifests as severe degree of hypertension. It may land up into a refractory hypertension. This is the flow chart which tells clearly about how an hypovolemia can give rise to multi-organ failure. When we talk about hypovolemia because of the blood loss, we categorize the degree and severity of the blood loss based on the volume of loss which the individual suffered. And usually it ranges from the classification, basically is ranging from 750 to more than 2000 loss, and it has been, this is the spectrum which one sees, and then it is categorized as up to 750 as class 1, 750 to 1500 as 2, 1500 to 2000 ml loss is 3. Anything more than 2000 is usually classified under class 4, which is supposed to be a very serious category and giving rise to deleterious effect as far as hemodynamics are concerned, and urine output is concerned, and mental state, and what it requires for us to intervene to replace the fluid in the form of crystalloids in the first two categories, and to support the crystalloids along with the blood in the third category, and basically blood for blood in the fourth category besides crystalloids. So we have a ratio of 1:1, and to replenish the lost volume depending upon the severity of the classification of the hypovolemia. The most important nursing management is to monitor the vital signs, send the samples for investigation, and basic investigation, which is mandatory, is to have a grouping and cross-matching, and to see that we have a proper intravenous access for significant transfusions to take place. And also side by side, as the transfusions are going on, one has to pay attention to the fluid overload so that you don't add extra insult onto the fluid overload by causing extra damage onto the already compromised patient's vital status. And oxygen delivery to see that the SATs are well maintained, and other medications in the form of vasopressors and so on and so forth also should be pushed at the same time. When the bleed is beyond control, we get into something called as an active massive transfusion protocol when needed. And if this happens if the patient after initial intravenous fluid therapy is still unchecked and uncontrolled, then we have to press the panic button onto the massive transfusion protocol. Bleeding is most important step in the management of hemorrhagic shock. So by some means, we should see that the bleeding is under control. Otherwise, we are likely to lose the patient. So there are various methods by which we try and take control of the bleeding. If it's an overt clinical evidence that there is a bleeding from a major vessel or a significantly major vessel. So if it is a distal limb where there is a bleed, the application of pelvic stabilization and tourniquets play a very good role in control of the bleed. Angiographic, if the patient is stable enough and before you feel that the patient deteriorates, we can have an angiographic study and embolization of the artery which is bleeding, which is a very effective means. It gives us a stopgap arrangement and as a bridge for further therapies. There's something called as REBO, and for those people who are not aware of this, it is an acronym in which it stands for resuscitative endovascular balloon occlusion of the aorta, which is very effective if you can place proximal to the bleed and take care of the bleed and control the bleed. And local hemostatic agents, if it is a minor bleed, the hemostatic agents do have some sort of a positive response, but if it's a significant from a significant artery, then the local hemostatic agents are of not much of a help. The other category which we usually see is the cardiogenic shock, and basically because of the left ventricular failure, and the commonest denominator which puts the individual into this category of cardiogenic shock is myocardial infarction. So all of you must have witnessed this, and an evolving myocardial infarction or with a very poor left ventricular function or a major left ventricular dysfunction can lead to such a clinical picture, or a postpartum cardiomyopathy, drug-induced. We can add havoc to the already damaged myocardium, especially beta blockers and calcium channel blockers. Or it can be left ventricular outflow tract obstruction because of some reason, giving rise to a mechanical failure of the left ventricle. It can be a severe tachyarrhythmia where there is no filling time for the diastole, something more than 170, or it's a severe degree of bradyarrhythmia. So we have the arrhythmia category, we have the non-mechanical left ventricular failure category, then we have the mechanical failure category, and last but not the least, and it is the right ventricular failure. All these can give rise to a cardiogenic shock. Slides are gone. Give me a minute. Yeah. This is another pictorial depiction of the cardiogenic shock. The progressive cycles of inflammation, ischemia, vasoconstriction, and volume load. And anything which goes wrong with all the indices of systolic blood pressure less than 90, cardiac index of less than 2.2, cardiac power output of less than 0.6, lactic acidosis, all these keep building up once there is hypertension and can give rise to fall in the cardiac output, multi-organ dysfunction, and unfortunately lands up into death. The nursing management of cardiogenic shock is preferably should be managed once you diagnose that the etiology of the shock is basically because of a cardiac problem, then the patient to be moved into the cardiac care unit, monitor hemodynamics, give oxygen therapy, judicious use of fluids. Here you have to be very careful. It's not like a hemorrhagic shock where you pump in fluids. You have to be very judicious in the fluid therapy so that with careful monitoring, and the monitoring will be central venous pressure, and administer medications and intravenous fluids. If there's no improvement in the perfusion with the fluid challenge, or there is hypoperfusion and pulmonary edema, vasopressors and inotropes are to be considered to tackle this situation. At times when whatever you do, the blood pressures will not come up to the satisfactory level as desired, especially in post-cardiac surgery, where it is very difficult to get the patient, if we are working on an on-pump. In such cases, the patient may show signs of shock, which is hypovolemic. So in such cases, we use a device for those people who are aware of it. It is called as the intra-aortic balloon counterpulsations device, which you're seeing over here. This is the IABP device with the balloon inflated in the diastole, and this is the balloon deflated during systole. This support should be instituted as quickly as possible, even before any transfer for revascularization in very sick cases, which can get into irreversible state. And prepare the patient for revascularization if you have identified the cause, if it is cardiac, and ensure safety and comfort for all the patients when they are subjected for IABP. IABP is very helpful and a very useful invasive device to manage hypovolemic status of shock. We also dealt with in our previous slides about the obstructive shock, which is basically because of the obstruction to the outflow. And the obstruction is basically because of tension pneumothorax, some sort of a tamponade around the heart, like a cardiac tamponade, pericardial effusion, massive pericardial effusion, which acts as a tamponade, or it can be pulmonary embolism. Pulmonary embolism is not that rare as we think. It is a very common accompaniment, giving rise to some sort of an obstructive shock and an abdominal compartment syndrome. Any rise in pressure due to any reason, mostly it is because of trauma. It could be because of the blood in the peritoneal cavity or some contents, or it can be because of some sort of a peritonitis with some pathology in the abdomen. And these can push the abdominal contents onto the mediastinum and can mimic an obstructive shock. So to tackle such situations, you got to do control and manage the primary source, whichever it is. And if it is tension pneumothorax, the common thing which you are supposed to do is put a whiteboard needle into one of the chest space on the second intercostal space and de-air the pattern, and later on put an ICD. And we'll try and evaluate what is the cause of the pneumothorax. But by doing this, at least you have averted a severe obstructive shock. Otherwise, you would have allowed the patient to collapse. Pulmonary embolism, once you diagnose, based on the history from the attendance or the nature of collapse, the patient's history is, and with supporting diagnosis, you can treat it. Most of the times, it is treatable and reversible. Abdominal compartment syndrome, you have to do an exploratory laparotomy and attend to the problem which has caused this sort of a clinical picture where it has distended the abdomen, giving rise to these high volume shifts or an obstruction in the peritoneum, causing secondary obstruction into the mediastinum. Obstructive shock is usually mechanical obstruction on the heart, maybe because of the blocked vessel, but Inadequate filling, which can cause inadequate filling, inadequate pumping, and there's a fall in the oxygenated blood to the tissues, resulting in the final common pathway of whichever shock it is. Finally, it lands up into tissue hypoxia and cell death. The common features where one can try and diagnose obstructive are respiratory distress, tachycardia, unexplained sudden hypertension, tachypnea. There'll be a lot of air hunger, chest pain, dilated neck veins because of the obstruction. The management is study the hemodynamics, monitor them, investigations as soon as possible, hemodynamics and blood investigations and radiology, oxygen therapy, and treat the underlying etiology. And it is amenable very soon for the correct treatment given. This is the same thing with a different note of differentiating the types of shock. And this basically we have classified them into the 4 types, and the clinical profile which is usually seen along with the specific features which one sees in the relation to the shock as far as the central venous pressure is concerned, or the hemodynamic status of the left heart, the pulmonary capillary wedge pressure, which we seldom do nowadays. It is falling into obsolete indication nowadays. Cardiac output, we need not be very invasive on this. We have some semi-invasive or non-invasive techniques to do these, and the systemic vascular resistance and the others. These will help us to diagnose and pinpoint on which type of shock it is and how to classify them and how to study which end of the spectrum are we giving rise to, what are the indications for the various therapies, which we have to do it as soon as possible. This is the same thing to show the various other about which percentage in distributed shock and the others like hypovolemic and cardiogenic and obstructive. As we have gone through our previous slides, the maximum shock which we day in and day out see, the maximum chunk is getting classified into distributive, which is to the tune of nearly 60 to 70%. And once we study the other parameters in the form of hemodynamic measurements and giving proper basic treatment, we can try and manage these type of shocks as soon as possible with no deleterious after effects. This is the presentation of the shock in a nutshell, and these are the lines of management, especially in relation to the nursing management. And I've tried to put most of the information in all the slides put together. I'll be very happy to take any questions if they are there, but I want all the nurses especially to understand the pathophysiology, understand the essence of taking care of the patient once they reach the ER, and to start off with what investigations to do and what should be the line of management in all these 4 categories of shock. I finish, and I also wanted to place on record that today is the Teachers' Day, and I want all the teachers who are associated with the ISCCM a very happy Teachers' Day, and I wish a lot of good luck to all the nurses and the other people who are linked to this presentation. I'm done.
Thank you, Dr. Murthy.
I'm done with Bose.
Thank you, Dr. Murthy, for your very informative and crisp information and lecture. So may I ask the attendees to ask some question to sir
Yes, please.
if there is any doubt.
Sir, please ask them to write in the chat box.
Yeah, you can write in the chat box also, so that we can go through it.
I have in the chat box Happy Teachers Day. Happy Teachers Day to all of you. Are there any doubts or anything related to the topic of discussion? My chat box is empty now.
You can unmute your mic and talk to sir also directly.
Okay, if there are none,
I
then
think
I would. If there are none, then I would like to close the session and wish you all a great time and good luck. And thanks.
yeah, and